In this lesson, we're going to talk about the different levels of consciousness you might see in your patients. This plus your pupillary assessments are going to be the staples of your neuro exam. We'll talk more about the pupil assessments in the routine neuro assessments lesson. Now, in order to understand the varying levels of consciousness, we need to know what normal is. So let's talk about what a normal neuro exam would look like. This is someone who's considered conscious. This would be like you and me. We're awake. We are alert. We are aware of our surroundings. If they are asleep, we'll just give them a chance to wake up. If they arouse easily and they're able to remain alert, then that's normal. Then we ask the patient 4 questions. What is your name? Where are we right now? I usually go with what month is it? And the reason I do that is because half the time I don't even know what date it is without looking at my phone. But if they get the month right, we know they're pretty close. And then we'll ask them something like, why are you here? Or why are you in the hospital? And that will give us orientation to person, place, time, and situation. Now, if they get all 4 of these right, we're going to say they are alert and oriented times 4. Now, some facilities don't actually use situation, so you would just say alert and oriented times 3, and that would still be appropriate. And then, of course, somebody who is alert and oriented is able to follow any commands that you give them. Now, the next 2 levels of consciousness are patients who are alert, but they are not oriented. So people who are confused, they just can't answer all the orientation questions correctly. You might say that they're alert and oriented times 1 or 2 or even 0. They just have difficulty following commands. They're kind of slow thinking and they're having difficulty tracking what's going on, and they may even have some memory loss. Now, this can be caused by sleep deprivation, which actually happens a lot when patients are in the hospital. It can even be caused by infection. In fact, the number 1 sign in the elderly of infection is confusion. And then remember from the cerebral metabolism lesson that hypoglycemia can also cause some confusion. Now, the next step down from that is going to be delirious. Delirious patients are confused and disoriented, but they are also tend to be restless or agitated. They may have some hallucinations or even delusions. I actually had a patient once with ICU delirium who swore there were spiders crawling up the wall. They're going to have trouble paying attention and focusing on what's going on. And they're really just having difficulty keeping touch with reality. Now, this happens a lot in the ICU, sometimes because of sleep deprivation, but also because of some of the meds we give them. They're really just kind of losing touch with what's really going on. And then we also see delirium in Alzheimer's patients when they're sundowning. Now, the next level are going to be patients who are only minimally responsive. They are not alert. Now, patients who are somnolent are excessively drowsy. They are excessively sleepy. Think somnolent, sleepy. Now, this is not you after you just pulled an all-nighter studying. This is excessive. They're really hard to keep them awake. They just keep falling back asleep. You try to arouse them, they might just mumble at you. And this is the point at which we start needing to use painful stimuli to try to get them to respond to us. Now, we want to give them credit for the best response they give. So we'll start with something like nail bed pressure that's just kind of annoying. And then we could try a trapezius squeeze. That's the little muscle in the back of the shoulder. And if that doesn't work, we're going to move to a sternal rub just to see what kind of response we can get from the patient. Usually somnolent patients will open their eyes, they might mumble at you, and they may even swing at you, and then they're going to go right back to sleep. It's excessive. Now, obtunded is a little bit different. This is someone who might actually be awake, but they're really not alert or aware of their surroundings at all. They are not interested. It's like the lights are on, but nobody's home. Now, their responses are slowed, or honestly, they might not even respond at all. Sometimes it's like they're just staring right through you. And honestly, they may also have some delirium with it, just depending on what's going on. This could be caused by something like a stroke or elevated ammonia levels, which we'll see when we look at hepatic encephalopathy. Now, from there, we're going to move down to patients who aren't responding at all. Now, stuporous patients, they're in a sleep-like state. They are not moving around on their own. There's no spontaneous activity. They do respond some to stimuli, but only with grimacing. Sometimes they might pull away from you when you cause that painful stimulus. Again, we'll start with things like nail bed pressure, trap squeezes, or sternal rubs. And it just depends on kind of how they're responding. But the amount of response we get from a stuporous patient is very, very, very minimal. They're not going to open their eyes. They're just going to kind of pull away and maybe grimace to pain. Again, we do use the increasing level so we can give them the best credit. And then finally, we use the term comatose for patients who are completely unarousable. They don't respond to any stimuli, even those super deep sternal rubs. The only other thing we really need to assess on these patients is whether or not they have a gag or a cough reflex, because we need to know whether or not they're going to be able to protect their airway. So we'll use that Yankauer and we'll stick it in the back of their throat and see whether or not they have a gag reflex. The number one concern here is that they're going to have trouble protecting their airway. And if that's the case, we need to assess for airway protection and get help as soon as possible. Now, any of these neuro changes could be attributed to any number of diseases, from cardiac to respiratory to metabolic to neuro. The most important thing here is to recognize the change and notify the provider so we can begin to identify the cause. And again, if you remember from cerebral metabolism lesson, the brain is very sensitive to low oxygen and low glucose. So make sure you check your patient's SpO2 and your blood glucose levels before you do anything else and while you're waiting for the doctor to arrive. So remember, when we assess level of consciousness, we are first assessing whether or not they are alert and awake, and then we assess their orientation level. If they're oriented times 3 to 4, then that's pretty normal. If they're oriented times 1 or 2, we're talking about them being confused, possibly even delirious. We want to figure out what the cause is so that we can address it. Then if they're not alert and oriented, we want to use some painful stimuli in an increasing fashion to figure out what their best response is going to be to that pain. So your basic levels here are going to be normal, alert, but not oriented, minimally responsive, or no response. That would be like a coma. So remember, if you notice of any of these changes, you need to notify the provider right away so that we can deal with whatever the problem is. So make sure you check out the next few lessons to learn more about routine and adjunct neuro assessments. Now go out, be your best selves today, and as always, happy nursing.